I would like people to understand maxillofacial surgery is a little bit different to just being a dentist, a bit different to just being a doctor, to balance both hats. And we have a unique set of surgical skills, as every surgical specialty does.
Welcome to Australian Specialist Hub's podcast, The Consult, and I have maxillofacial expert Dr David Sherring joining me today.
Thank you, Hannah.
Tell me about your journey. What drew you to medicine and how do you find your way to the specialty that you're in today?
I guess like a lot of dentists, I initially wanted to do medicine and didn't. I hated dentistry, which, sorry to all the dentists out there, but that's what happened for me.
Why did you hate it?
I struggled with it for the first few years of the degree, to be perfectly honest with you. I found it tough going. I guess I wasn't that interested at that point. The last couple of years were fine. I guess I always had this hankering to study something beyond dentistry. I didn't know what that would be or different to dentistry. So when I finished dental school, I joined the army because that was a way of being paid to go camping and and not have to be a dentist that much. And that was a great introduction, I guess, to dentistry. A prosthodontist is my first OC. So that was great, having someone on site. And there was a lot of support in the army. So it actually settled me down into dentistry. And then I got deployed to Rwanda and working over there with a lot of non-dental stuff, a lot of the work that I did over there. And that, I guess, put my interest back into perhaps studying medicine. The reason I did maxillofacial surgery is I was a dentist and it seemed to make sense that I'd combine the two. So,
and as we were speaking about earlier, it amazes people the amount of training involved in becoming a maxillofacial expert.
Yeah, so we all have dental degrees, we all have medical degrees, and we all do surgical training. And then usually, as with most surgical specialties, some sort of post-fellowship training from leaving school, if you like, at the age of 18 to when you get your ticket. As a minimum, it's generally around 13 to 15, 16, 17 years. There'll be some time in there where you're not formally training, but it's a long process.
And we were just talking about that maxillofacial is the orthopaedic surgeons of the face, which I thought was an excellent way to put it.
Yeah. Look, people don't really understand maxillofacial surgery. The lay people don't, and even other medical specialists, practitioners don't really understand what we do. I think it's because we're such a small specialty. There's not a lot of exposure to our specialty, either during medical training, and a lot of hospitals don't have maxillofacial surgeons on staff. So if you're not in that environment, then you wouldn't have an understanding of our depth of training and what our scope of practice is.
And I think there's definitely a lot of confusion, I know in the medico-legal world, of which particular cases go to a maxillofacial and which go to a dentist or which go to a prosthodontist, and where each of those lines draw. So I know our team, they run a triage service where we get just a bit of an outline of a brief case, and we've sent that through a few times, which has been very, very helpful.
Yeah, so look, as maxillofacial surgeons, the interface between medicine and dentistry, we're the only health practitioner that must hold both a dental degree and a medical degree. Now, certainly there are other specialists out there who might happen to have a dental degree. I'm not too aware of other dental specialists that might have a medical degree. Generally, if you do that, you're going to maxfac surgery, but there are certainly some ENT and plastic surgeons around who do hold dental degrees, although that's uncommon. Yeah, so I think understanding where that interface between medicine and dentistry means that we can bridge that gap when there are injuries or concerns that might need dental input as well as input from someone who understands injuries in the head and neck region or pathology of the head and neck region. When it comes to other dental specialties, again, I don't profess to be an expert in any other field of dentistry other than maxillofacial surgery. And when reporting, I can pass an educated opinion on dental matters. But if I think it's something that would be best managed or commented upon by a specialist, for example, a prosthodontist or an endodontist, then I'll make that clear within my report. And what people do with those reports is up to them, but I won't hold myself out to be an expert in those fields of dentistry if I think that's at the crux of the case.
And it's so important when you're giving expert evidence that you are staying in that realm of your expertise.
Absolutely. Yeah.
We were just talking about when an examiner is coming in to see you, what that looks like, because I think a lot of people are expecting maybe a dental chair, or they don't know what to expect. Is there going to be a light going in my mouth? Sort of what does that look like?
Most people dislike dental chairs. Just there's a visceral reaction when you walk into a room and there's a dental chair. So I, throughout my practicing career, have never had a dental chair in my consultation room. I have a desk and chairs, and I sit and talk to people, and the majority of the time the examination can be conducted within that office. I reserve a dental chair for when I'm actually treating someone. So I have the ability to fully assess a patient pretty much anywhere, I guess, from that point of view. Need a headlight, that's all.
And making them feel comfortable, not scaring them away from a dental office.
That's the goal. If people are relaxed, they tend to be more open, perhaps shouldn't say honest, but forthcoming with the information that you need.
In your area of medicine, what are the most common types of matters that come to you through the medico-legal system? And what does that thorough assessment in your specialty actually look like from your end?
There are assessments that would be specific to maxillofacial surgery, and then there are those that might sometimes be done by ENT or plastic surgeons, so there's a little bit of crossover there. The ones that are the crossover are generally facial trauma, maybe head and neck cancer, that type of, and some of the pathology would cross over with ENT or plastics. When it comes to specifics for our specialty, then it's often temporomandibular joint problems or temporomandibular disorders, which includes joint muscle, jaw clenching, grinding, those types of issues, which are very common questions asked in the letters of instruction. The sequelae, I guess, of treatment is also something that's raised in some of the medical negligence cases, where there's questions about whether the claimant, their injury has arisen as a reasonable sequelae to their treatment, or whether it's indeed something more significant and perhaps should have been picked up earlier.
And you're seeing a huge variety of medical negligence cases come through?
Yeah, there is, yeah. And look, some of the medical negligence cases are purely dental related, teeth injuries or, that type of thing, all the way through, as I said, to, facial trauma, temporomandibular joint replacement surgery, those types of cases as well. So there's a broad spectrum.
One case I remember from your previous presentation was a cow that had come through a lady's windscreen, and that was just an amazing transformation of where she was to where she'd got after being treated.
Yeah, so I guess that's the majority. There's very few maxillofacial surgeons practicing in Australia and New Zealand. There's only a few hundred of us that are registered with the fellowship, and we do tend to see the more significant trauma cases, and certainly our training throughout the 4 to 5 years of training that we do is centred around trauma and head and neck pathology. So they're the two areas where our training is significant, I guess. We do also look at facial deformity, so faces that don't grow quite right, and we do corrective surgery for that. And unfortunately, that can also be a source of medico-legal questions at times. And again, we would be the only specialty that does that type of work, who has been trained to the standard that we have. Our trainees all spend their 4 years working up and doing that type of surgery as well. So I think that's where we differ from some of the other specialties that deal with facial trauma or with faces that haven't grown correctly or that type of thing, is we are limited in our training to the head and neck region, and we predominantly deal with bone surgery. With the only specialty that I would say gets the level of training to deal with bony injuries of the face, and we cross over a lot with ENT and plastics when it comes to the soft tissue type injuries.
It sounds incredibly intricate. I recall you saying even something being out sort of $250,000 can cause an enormous disruption to someone's livelihood.
Yes. Look, where we perhaps differ is in our training, and being dentists, we understand the importance of occlusion, how teeth meet, and we can pick up, as in people can pick up, very small discrepancy in their bite. If you put a few hairs between your teeth, you'll be able to feel them. When you're dealing with fractures of the face and jaws, they often impact on the position of the teeth. And so as maxillofacial surgeons, we're always mindful that the most important part of that operation is to get the occlusion correct for the patient. What we don't want is to be doing this surgery and then having the patient come back and complaining that their bite feels out. And it might not be something you can see, but they can feel it, and it's incredibly irritating for them. It may then necessitate further surgery or referral to an orthodontist, and so the treatment goes on. But if you get that right at the initial surgery, then you negate any need for those additional referrals and treatment for the patient.
Wow. And even taking into consideration the psychosocial effects it has on people. And I remember you saying that different cultures interpret different features in the face to be different things, which I thought was very, very interesting, whether the jaw was put forward or the top of the jaw was put forward, what that was interpreted as in different cultures.
Yeah, so that's when it comes to our surgery to correct what we call skeletal deformity. We use the term deformity, skeletal malposition. So where, for example, the mandible is too short. So people might have surgery to have their mandible advanced, and that needs to not just be driven by tooth position, but also by the facial aesthetics. And so, again, that's something that medical practitioner as well as a dentist, we tend to look at the whole picture rather than just concentrating either on the external appearance or on the dental occlusion.
Totally holistic. Where do you see the biggest gaps in how your specialty is currently understood or assessed in the medical legal system?
I think the problem that we have is, probably alluded to this earlier, is we're a very small specialty. There's only between 200 and 300 registered maxillofacial surgeons across Australia and New Zealand. So it's a specialty that isn't well understood as to our scope or our training and where our core competencies lie. And so I think that's the gaps in the understanding of the scope of our specialty and where our training skills lie, I think. We have, as most surgical specialties do, an organisation for our craft group. It's the Australia and New Zealand Association of Oral and Maxillofacial Surgeons, of which I'm a past president. And we have an annual scientific meeting annually, and it's very well attended. So that's our principal method of, if you like, catching up and cross-pollination between our colleagues in different states and in New Zealand. Many of us within the specialty either do or have held many hats because we're such a small specialty. So, for example, I had a full-time private practice, but also held visiting medical officer positions in three public hospitals. I was an examiner for the specialist basic exam and then for the fellowship exam. As I said, I was a counsellor and then past president of ANZOMS, and I'm not unusual in having those positions. Our training occurs in the public hospital system, so when you hold those VMO positions, that's where you get the opportunity to interact with the next generation of surgeons coming through. One of the public hospitals I was at didn't have maxillofacial surgeons, so I was training plastic surgeons. They would come for 6 months, and 6 months out of their 4 years of training, they said that was the most concentrated exposure they got to facial trauma and any maxillofacial type work, which I guess reinforces the point that our trainees do that type of work for the full 4 years of their training, whereas other specialties, because they have a requirement to learn skills that I don't have that depth of exposure and experience that we do.
Would you have any wise words of wisdom for any upcoming maxillofacial surgeons thinking about getting into medical legal work?
I'm enjoying it. It's challenging at times to work through what's being asked. Sometimes it's not clear whether the solicitors really understand the question that needs to be answered. At other times, I've had a couple of referrals where I suspect they were fishing for other information. Puts me in a difficult position at times where you don't want to go beyond the brief, but as you're writing it, you can see that you're starting to could easily creep into an area that perhaps you don't wish to go. So I think one of the challenges is sticking to what is asked in that letter of instruction, not speculating.
And making sure those letter of instructions are done clearly. Actually not the first expert today to bring that up, and it's quite common for experts to call me or the team and say, what are they actually asking? Because it's sort of a bit of a grey area with the questions, or sort of the history is not as clear as it could be.
Yeah, I think I'm not asking for more documentation at all because some of the briefs are long. I often find that critical information isn't provided in the documentation from my perspective, and I can't answer the question that's asked because that documentation isn't there. And when you go back, sometimes it can be made available and other times it can't. There's also an issue with the provision of that documentation. Some people, dentists or other surgeons, don't seem to provide the full information because you know what should be there as a specialist. And when that information comes across and it's not, you don't want to be putting in your report that you think there's an issue with the documentation, because that obviously is then potentially pushing into someone else's professional practice. But you actually need that information to be able to write the opinion that you're being asked. So that there's a tension there when it comes to documentation.
And is that images that should have been included, or is just so when our clients are putting together their letter of instruction, there is a bit of confusion about what should be included, what shouldn't be? I've had cases where the solicitor's gone, oh, are you sure you want all of the documentation? And the doctor's gone, oh, how much can there be? And it's being wheeled on 2 trolleys.
Yeah. Look, I think from my perspective, sometimes it's dental stuff that's missing, particularly cases where it's people that are claiming temporomandibular disorder based upon a psychological diagnosis following an injury, and that's a very common pathway and a very common area that we're asked to comment on. And there may be dental records subsequent to the worker's injury, but I'm also interested in dental records prior to. Was there a past history of anything in the patient's history to do with temporomandibular disorders? And why that's important is claimants aren't always totally honest, or probably more likely they forget a dentist has mentioned to them, oh, I think you might grind your teeth, or as a passing comment. But if the dentist has documented that in the notes, that's helpful for me, because I read that before I see the claimant. I can then ask them, oh, look, do you remember ever having any problems? Your dentist back in whenever mentioned it in the notes. Sometimes that jogs their memory, go, oh yeah, that's right. And I think it was related to whatever the problem was. So that can be helpful in clarifying pre-existing conditions versus, or an exacerbation of a pre-existing condition versus a new condition. So yeah, I think that's a very important component of the documentation that needs to be provided. The other thing that's often missing in those cases is psychological diagnosis. I'll get the claimant telling me they've got PTSD or they've got anxiety, but there's nothing in the clinical notes to indicate that that's been diagnosed, or perhaps it's been mentioned by a GP, and I'm not sure whether that is a diagnosis that is able to be held as equivalent of an expert diagnosis. So should that person have a diagnosis from a psychiatrist or a psychologist, or not? So again, I guess when you're sending documentation through to me, you mightn't think that you need to include the psychiatrist or the psychologist, but if it's potentially a factor in the claimant's maxillofacial condition, then it's helpful to have that information available.
I'm so glad you brought that up, because recently we have had a couple of cases where the examinees had bruxism and it's been suspected that it's psychologically induced, and the team's gone, okay, well, what do we do with this case? Where does it go?
Yeah. So I think, and I've probably seen those cases, and psychiatrists, quite rightly, I think, will say they are no experts in TMD. temporomandibular disorders or bruxism or that type of thing. Just as I will say I'm no expert in psychological medicine. But between the two of us, if I've got a psychiatrist that says this claimant has this psychological condition, and if our literature says, well, if a person has this particular psychological condition, that they are at increased risk of presenting with temporomandibular disorder, then that can be written in the report. And that doesn't mean that the person's temporomandibular disorder was caused by the psychological condition, but there is evidence in the literature of an association. And often that's the best we can come up with, is there is an association between this condition and another condition. And I think speaking to lawyers, sometimes they like black and white. Did this cause this problem? And that's not how medicine works. Medicine works with associations. So there's an increased likelihood of a particular condition occurring because of the presence of this other condition. How medicine is, it's not black and white always.
It's not a clear yes and no, which is often what the law is looking for.
Yeah, that's exactly right. Yeah, and I think sometimes when they come back to you and ask supplementary questions, that's what they're after. And often I feel like I'm just reiterating what was put in the initial report. Is I can't say with certainty, but here's the evidence in our literature supporting my opinion. And I think that's the other thing, is where I'm putting forward an opinion where it's not black and white, I will generally try and back that up with literature, often maybe a systematic review or something fairly recent that's canvassed the literature. And that's not to say that that's a perfect way of doing it. And those systematic reviews may not have a lot of good quality data in it, but it's sometimes the best that can be done to try and support an opinion.
And given how few maxillofacial surgeons there are in Australia, I can understand why.
Yeah, look, we're a relatively small specialty worldwide, but particularly in Australia, very small.
What makes your assessments and reports stand apart?
I don't know.
Okay.
I'm not sure. I hope they don't stand out for the wrong reasons.
No, I always get the feedback that they're very useful, so
No.
that's good.
I try.
So at the consult with Australian Specialist Hub, it's a bit of a tradition to ask our experts some quick fire questions.
Right.
What did you want to do before medicine?
Wouldn't be in the army. There you go. At one
That's a
point.
good one. I like that one. What do you do to wind down?
Look, I love running and cycling, so if I can, I get out the door and do something physically active. Live on the beach, so summertime swimming and surfing, that type of thing.
Did I hear you recently did the New York Marathon?
I did.
Wow.
It's great fun. The atmosphere was amazing.
Wow. How many people did the race?
Look, I think it was close to 60,000 finishes. And the crowd lining 42 kilometres, and wherever there was footpath, there were people, 3 and 4 deep the whole way.
What is something about maxillofacial surgery that still amazes you?
I think it's amazing how the body heals after either what's done to it or what we do to it. It's amazing how maxillofacial surgery has evolved to allow us to do the surgery we do. And I guess my colleagues that reconstruct after tumour ablation, for example, where moving tissue from elsewhere in the body and putting dental implants in to that tissue, all at the time of the tumour ablation surgery, and they might have a prosthodontist in theatre to fit a bridge, and so the patient is in a terrible situation, but they're put under anaesthetic, they have their cancer removed, they're reconstructed, they wake up, and they'll have some marks on them from the surgery, but functionally we're getting much better at being able to rehabilitate our patients. Would imagine losing an arm would be awful, but I think losing your tongue or part of your jaw and not being able to eat or talk, possibly worse. And what my colleagues are doing now amazes me. Yeah, that's far beyond anything that I was able to or was trained to do.
Wow, it's a specialty that's just rapidly evolving.
Yeah, so I think certainly maxillofacial surgeons have pushed that reconstructive process. Certainly internationally they have. And within Australia, there's several centres where maxillofacial surgeons do head up rehabilitation type work with remarkable outcomes.
Incredible. What's the most interesting or unique case you've ever seen?
I don't know that I've had much experience with unique and public hospital jobs. I was on call in the middle of the night. They had a young German tourist and they were down near Jamboree in a car, and a cow had come through the windscreen, and this fellow had what we call pan-facial fractures. So he'd fractured all the bones of his face, with the exception of his mandible. Somehow that survived.
Wow.
So that was a life-threatening injury, so it required a tracheostomy and then later major surgery to reconstruct his face. I was doing a 1 week in 3 on call, and 3 weeks later, lo and behold, I got a call from the same registrar saying, "You won't believe this, Dr Sherring, but it's another patient from the south coast and it's another cow through the windscreen." And this was a young woman who did break every bone in her face, and she had exactly the same pathway. And look, that surgery is not common. We don't see a lot of pan-facial fractures where, to the degree that these people had the injuries. And so the length of time, I think the surgeries, sort of 14, 16 hours long to try and get these faces back together again. And just the time that these people take to recover, not just in hospital, but then out of hospital. And then this is where I guess the crossover with my dental colleagues comes in, where they need some dental rehabilitation and maybe an ophthalmologist because there's eye injuries and
the breathing as well.
Yeah, I was going to say ear, nose and throat. In that situation, you're just trying to get things back as best you can, but revision surgery of the nose and so on is all part of it. So I think that's probably been the most challenging type work that we do.
Such long surgeries. How did you go with the fatigue of the surgeries?
And all surgeons would say the same. You just get into a zone. You're not aware of the passage of time. I'm sure everyone else in the theatre is aware of the passage of time. but when you're in the thick of it and concentrating, time just goes.
You're just on the mission.
And it's not something where you can knock off for a few hours and come back and have another crack. Unfortunately, you need to keep rolling on. Yeah.
Fantastic. Absolute pleasure having you here. Thank you so much for your time.
Yeah, thank you, Hannah. Enjoyed it. Look, I would like people to understand, I guess, that maxillofacial surgery is a little bit different to just being a dentist, a bit different to just being a doctor, to balance both hats. We have a unique set of surgical skills, as every surgical specialty does.
Definitely unique.
Yeah.